Welcome back. You're listening to the discussion RX for the Federal Healthcare Transformation through IT, sponsored by Infor on federalnewsradio.com at 1500 AM. I'm your host, Jason Miller. My guests today are Colonel William Baez, the Chief Medical Information Officer in the Office of the Air Force Surgeon General, Andrew Jacobs, the Technology Strategy Branch Chief for the Defense Health Agency, Wayne Bobby, the Vice President for Infor Federal, and Beth Myers, the Chief Nurse Executive and Analytics Strategy Director for Infor. We were just finishing last segment talking about expertise and decision making, and Beth brought up some very interesting pieces and parts around the fact it's not being done quite as much as maybe it should be or needs to be, and it's maybe but a growing field. And Colonel Baez, you wanted to jump in here and talk a little bit about what you're seeing, because that's a big issue, I guess, for the Air Force Surgeon General's office. Well,
not so much an issue as I wanted to highlight the fact that there's a lot of interest in being able to have information at the ready when you're making a point of care decision, or a decision when you're treating a patient. And so we've definitely relied on the experts in the field to give us that perspective, through all of the decisions really that we've made as far as advancing healthcare and the modernization of healthcare. And the thing I wanted to say is that I think that's where we are really excited now as we're moving into this tri-service record that hopefully will be a successful, active duty and Veterans Administration record, is that now we're learning from the civilian partners who use the same system. And so instead of trying to take a best practice from a civilian hospital and then model that or mold it into some kind of a military practice, we're literally looking at doing it the same way that they do it, using the same medical record that they use. And so we're really excited about moving forward in that respect.
Is that taking a commercial and making it into something that you guys can use? Is that the 80-20 rule? You always hear that about customized systems, right? If you can get 80% of the commercial system and then only customize that 20% or less, or are you guys looking at the full 100 or 99.9%?
I would say it's the full 100%, because what the Cerner has been able to do, they're one of the partners inside of the MHS Genesis, is they're giving us a record that can be, you say customized, but we're going to configure it, right? So we're not really changing the back-end coding. Right. We're just looking at turning on some options and turning off other options. And a lot of the decisions that feed that process are benefited by the discussions that we're getting to have now with other folks that have been using the Cerner product, the Millennium, and the Dentrix product on the dental side. And so it's an ongoing discussion, really.
Wayne, jump in here, because as you heard Colonel Baez talk about the customization versus commercial use, take it off the shelf. Mm-hmm. I want to jump in about this idea of decision-making and expertise from a long-term perspective. Before we go there, just talk a little about what you're seeing. Are a lot of healthcare providers, whether public sector or private sector, that Infor works with, are they following the same path as what we heard from Colonel Baez?
Yeah, let me take kind of a 10,000-foot view first, and then
he's from the Air Force, so he's like 50,000.
So we'll take a 50,000.
That's the first joke.
Yeah. So let's do that, and then I want to start to share a customer story that perhaps Beth could finish for me, because she's had a little closer experience with this than I have. But so when you think about the challenge here, which really is an informational challenge, where as I view it, and as I talk to folks in VA and in military health, they all kind of see it much the same way. That is, so you have that enlisted soldier that maybe, you use the example of the enlisted soldier, man or woman at 18 years old that decides to join the service, and they come in, they take their very first physical, and that's where we start to capture that first bit of information about that soldier. And then they go through boot camp, end up in military theater or around the world someplace. And then over time, could be in combat, could be wounded, and treated, and that of course becomes a part of their medical record, of course. And then as a part during that same time frame, maybe they get married, they start to have a family, and then now you've got perhaps the spouse and the children going through the military health, clinics or hospitals and so forth. So now you start to capture a view of that individual and now that family that, over the course of time, they're much better served as a patient if you have that complete record. Of course, you start to have a family, and then maybe the child has a medical issue, asthma or something like that. So are we capturing all that information? Now that's really no different from any of us, if you think in terms of in the commercial world, that as we have healthcare in our daily lives, and we have some of the same challenges, not as a soldier necessarily, but starting a family, growing. You may over a course of time change medical providers based on jobs and that sort of thing. And then how do we carry all of that forward so we have that complete view? Because if it is an emergency, do we have all the information to properly treat that patient? Stories related to this is what took place at Hackensack University Medical Center. I would ask Beth to share that because she can share the details about it much better than I can. But interesting story to tell. So, and here.
Beth, pick up the story.
I'd be happy to.
He set you up well.
He sure did. The story at Hackensack is that the CIO of Hackensack University Hospital, Dr. Shafiq Rab, went in with his daughter to the hospital when she had had an injury. And as the CIO, he was embarrassed that they asked him the same questions over and over, and they had him fill out paper forms to capture his daughter's medical history when she was first admitted. And so Hackensack worked with Infor and our interoperability solution to connect through APIs to the electronic health record so we could collect that data and verify that data, what was already in the EHR, and then collect additional data about the acute injury directly through an electronic format, so they didn't have to ask paper forms. They didn't ask the question more than one time, and then they were recording the source of truth directly from the person that it happened to. And so that creates a verifiable source of truth, and you can share that information through interoperability, through things eventually like blockchain, where it's secure, we know it happened one time, and it's recorded in a place that we can share across all the systems.
It's a great example. Andrew, jump in.
So I'd like to, on Wayne's use case there, that was a very good use case, but I think it also demonstrates kind of that direct care perspective, in the sense that even though you're tracking them from the beginning of entry all the way till retirements or even final rights, depending on what happens, that's still a small percentage of visibility from a data perspective that we even have on our patients, to where with the advancements of technology, when we start talking about the Internet of Things and being able to collect more of that information that is not necessarily part of that direct care as they're coming into the hospital, but more along that virtual health care, where we need to do some more expansive work into to actually engage with them more proactively versus reactively as they're coming into the hospitals or coming into the clinics and everything. So I think your use case was a very good one to kind of illustrate this linear beginning to end. But as we've developed more technologies and advanced more in our communications and how we do our data analytics, we'll be able to bring in much more information using these smart devices that are out there.
And Andrew makes a great point. Colonel Baez, let me turn to you for a second, because one of the things that he's bringing up is this quality of care and the cost of care, both through technology and the way he, as Andrew described it, can bring down the cost and improve the care. What is the Air Force doing around the technologies, or you're looking at, or what types of technologies excite you, if you will, about that can do both improve quality and lower cost?
Well, certainly the use of telehealth in the Air Force has been a big advantage. We've used telehealth within the realm of the clinics and the hospitals, allowing provider teams or healthcare teams to request radiographic images, and then have a radiologist who's not even in that facility but somewhere else be able to read that and then give that information back in a very quick amount of time. So there's little delay, whereas if you didn't have the specialist in-house, you'd have to wait for that information. So that does help us with the reduction of care. And then moving forward, we see telehealth doing things like reaching out to chronic patients, in the sense that now a patient can have a virtual medical visit without having to drive. I think Wayne was talking about that earlier, not requiring that 1.5 hour drive that sometimes people have to make to get to a major medical center, but instead they have a virtual medical visit with their specialty provider, and they get the care they need. They're able to ask the questions that they need to ask, and we see that as a way to cut costs, because that will hopefully get us to a point to where more and more we're preventing folks from getting to a more serious disease state where they need to use the emergency room or the urgent care clinic, or perhaps even chronic stays long-term stays in the hospital. So we see that. To the point about leveraging current technologies, perhaps not in the line of care, but leveraging the internet. We do leverage social media and online communities as well to improve the patient experience, kind of going back to getting folks a little more satisfied, a little more connected to their patient-centered medical home. So it isn't the traditional view of healthcare, which is it's whatever I do in my doctor's office. It's now, how do I interact with my doctor, the provider team, perhaps other patients in the community when you talk about folks that are managing a chronic condition. And we're seeing good satisfaction from that. We also have a patient portal that we use that allows patients to send secure messages. So kind of like the telehealth, they're in the convenience of their home on their personal computer or perhaps mobile phone, and they can still reach out to their doc to ask a question, which overall saves costs because you don't have to get in the car, you don't have to wait for a visit.
Good point. So we've heard a lot about telehealth over the years. Beth, let me turn to you, since you have the experience as the Army Nurse Corps. Is telehealth different now than it was 5 years ago, 10 years ago? Not just because we're all more comfortable with it, but because of just the advancements of technology. I mean, and then where do we go next with telehealth? I mean, that's again, we've talked about it for so long. And when's it going to be here? But as Colonel Baez talked about, it's kind of here.
I agree. I think it's morphing and growing, and I'm actually a part of a group of nurses. I'm actually a part of a group of nurse informaticists who are thinking about those advanced technologies, and we are rebranding telehealth, and we've renamed our group eHealth, because it's more than just telehealth, where you think about an old CRT monitor and a physician going back and forth, and yes, so we're calling it eHealth, and IoT, the Internet of Things, really plays a strong role in that. And when you think about IoT, there's massive quantities of data. So data governance, data quality, and who owns that data all become are very pertinent, as well as the security of that data. Where does that data live? So I think it broaches an entirely new set of topics for us to think about.
And for a panel to think about too. I mean, you're opening the door to the data analytics piece. Wayne, talk a little bit about data analytics, because since Beth opened the door, that is the key. Right? When we talk about expertise and decision making, you got to have good data analytics. When you talk about telehealth, or as Andrew described, what decision should a nurse or doctor make about the interaction of a drug? That's all based on, in many ways, data analytics. So is that starting to be used in healthcare providers?
I think it really is. I think that and Beth is working on her PhD on the analytics stuff right now. She's in the midst of that. But the whole analytics thing, I think we're just kind of scratching the surface in terms of what can become. So this is one of these areas where clearly in the healthcare arena, and clearly when you're capturing this patient data, it's one of these areas where I like to say we're kind of data rich but information poor in terms of how do we make that transition. And I look at solutions, and one of the things that we see that's been growing in Infor is around care workloads. And so you picture, if you will, we know that that based on patient appointments and intake, we ought to be able to make some decisions about what kind of clinicians we need on staff. So we can look at solutions, and I like to share this example. So if Jason, if you were to end up in the emergency room and they were diagnosed that you had appendicitis, then that normally requires a 5-night stay. Well, so can we now automatically adjust the clinician's schedule to know that you're going to be in the hospital for 5 days, and that requires this kind of nursing care and maybe these types of other clinicians to be on staff, these doctors. So we're automatically adjusting up or down that clinician's schedule based on the intake or what's taken place over the course of time inside that healthcare provider or that unit, right? We're also seeing things getting back to a little about telehealth and use of some of these devices we all take with us today in our hands, things like Rate My Hospital, if you will. So I just came out of the VA hospital, maybe not 20 years ago, but today, everybody who's leaving that hospital going back to their car has a mobile device in their hand, and if you were to hit them right away and say, you just left the hospital, just left your appointment, how was it? Ask them 3 to 5 questions. People are going to respond. You keep it simple, and you're going to get that much better immediate feedback as opposed to sending them a survey in the mail. And so what kind of things can we do using analytics and data gathering to give us a much better perspective on that patient care?
Yeah. Andrew, let me turn to you. Wayne brings up an interesting point. We're talking a lot about the care to the veteran or the service member or the patient, but Wayne also brings up the back office piece to this, adjusting schedules. Is that something DHA is starting to look at in terms of work with the services, in terms of, hey, it's a nurse, it's a doctor, do we have enough orderlies in terms of the back office side of this discussion?
Oh, absolutely. That's actually one of the things we've been looking at on our long-range planning in the sense that we call it an active architecture. So when information is actually being generated in one area using machine learning and other technologies to actually adjust that on the other side. Example I love to give is kind of a Walter Reed example in the sense that we have smart parking out there. Okay, so the parking garages know when they're full and when they're not full.
I love that, by the way. It's my favorite thing. You walk up and you see 500 spaces available. Sorry.
That information typically goes to, whatever that smart parking server has, and then it's there. And what do they use that information for? Well, to plan for more parking. But actually tapping into that system and actually going, okay, the parking may be full, so this triggers an event, which then notifies either the care provider saying, hey, this parking lot's full, so they may have to take a shuttle because they're going to have to park in parking lot Z or wherever on the other side of the base. And then it triggers an event to go to even the onboarding patients as they may break a geofence with their smartphone saying, hey, you can't park in these garages, park here. And we've notified the care provider that you're going to be late for your. So being able to take all of that information in and have an actual active architecture in there to be able to take those events, process them, and put them where they belong. And being able to do that with all of the systems that we may have, to include industrial control systems in a hospital, to be able to start bringing in all that information and making that information, as you said, we're data rich and information poor, but actually leveraging that information to make even the stay better. Because the one thing that's really going to make you angry, in Walter Reed's no parking.
Exactly. All right, great examples. We're going to take a quick break and come back. We can continue our conversation. You're listening to the panel discussion, RX for Federal Healthcare Transformation through IT, sponsored by Infor on federalnewsradio.com and 1500 AM.